All right, we're going to talk just briefly about tone abnormalities. There is a lot in Chapter 5 that we are not going to go over, but basically I just want to define some terms and talk about what muscle tone is and what it is not, and briefly how we can address tone abnormalities using physical modalities. So we're just going to talk about muscle tone, what it is, what abnormalities of tone are, and define some terms, how you measure it, and what happens. So abnormal muscle tone and its consequences. So the learning objectives that I want you to address for this lecture are, I want you to be able to define muscle tone and describe how it is measured. I want you to define the terms hypertonicity, hypotonicity, rigidity, spasticity, flaccidity, and clonus. And we'll go through each of those. And then which physical agents might be used to treat which tone abnormalities. Okay, straightforward. So key terms, rigidity, spasticity, and flaccidity. So when we talk about in the physical fitness world, maybe talk about muscle tone as how you look, how you're not flabby, you've got muscle tone. But in the physical therapy world, we talk about muscle tone as the stiffness or slackness of muscles. So the condition that can change at rest or during muscle contraction, and there are different pathologies that are going to cause changes in muscle tone. So there are basically neuromuscular and musculoskeletal disorders that can result in abnormal muscle tone. And because abnormal muscle tone can affect function, we have to be able to define and assess muscle tone so we can make appropriate changes to improve function. So it's the underlying tension in muscle that enables a muscle contraction. So when we talk about rigidity, it means that you have an excess of muscle tone to the point where it's difficult to move. So you're rigid. Spasticity, on the other hand, is a velocity-dependent increase in tone. So you might be able to passively move somebody's arm that has spasticity, but if you move it too fast, it's going to tighten up on you. So spasticity, and we'll talk more about these individual ones. Flaccidity is where the muscle is just slack. There's no tone to the muscle. So when we're talking about muscle tone, we're talking about involuntary reaction. So it's not a muscle contraction, and it's not a motion restriction. There is some sort of involuntary change in the muscle itself, whether it's in the guided by the nervous system or internally. So muscle tone is the underlying tension in a muscle that serves as the background for contraction. So if your muscle is completely flaccid and you do not have any muscle tone, you cannot generate a muscle contraction. So you have to assess muscle tone when there's no active resistance to the muscle stretch. So basically you're going to do passive range of motion to assess muscle tone. Muscle tone is going to change with movement, posture, intention, and environment. So you can imagine, like, say you're going to assess, you're going to do passive range of motion on someone's shoulder into shoulder flexion. It's going to be different whether they're sitting up or lying down, what their posture is, what you're asking them to do, and what you're trying to assess. And if you're in a super cold room, it's going to be different than if you're in a super warm room. So lots of things can change your assessment of muscle tone. So tone abnormalities, hypotonicity is abnormally low tone. Hypotone, abnormally low. It's decreased resistance to stretch. Flaccidity is the total absence of tone. It is a hypotonic condition, but it means you have no muscle tone. So a lot of times immediately after a stroke, someone's muscles will be flaccid, and then later on they develop hypertonicity. So hypotonicity can occur in Down syndrome or other genetic disorders. It can occur with poliomyelitis. You'll see a lot of, when you talk about pediatrics next spring, you'll see that a lot of the genetic conditions that we talked about in pathophysiology result in hypotonic trunk muscles. So it changes their posture and strength and walking and everything. So a hypotonicity is abnormally low tone. So the opposite, hypertonicity, is abnormally high tone. So there are different types of hypertonicity. Rigidity resists stretch regardless of velocity. So a lot of times when we're talking about something like Parkinson's, where there are changes in the movement control systems, the rigidity, you're stretching someone, and there are really two types of rigidity, and we'll talk more about these. But lead pipe rigidity, and it's basically like you can't move their arm. It's really difficult. It's like, pushing a boat through mud. Or cogwheel rigidity, where it catches and releases. That's the cogwheel. Spasticity resists stretch at higher velocities. So if someone themselves is trying to do a fast movement, they might get more spasticity. Or if you are moving their arm fast, or their leg fast, or their ankle, you might get more spasticity. Clonus it's rhythmic oscillations or beats of an involuntary contraction in response to a quick stretch. So a lot of times people with neurological disorders have clonus. MS is one with a lot of clonus. A lot of times after strokes, people will have issues with clonus. And it's basically you put someone into dorsiflexion and their foot taps multiple times. It can occur after a stroke. One time I was working with this really super sweet guy with MS that had a lot of clonus, and we were doing, I think we were getting onto a recumbent stepper to exercise, and his clonus was really acting up. And there's some techniques that you'll learn in neuro rehab class for diminishing clonus, but he's like, "Oh, clonus, why you gotta do me this way?" I just thought it was so cute when he said that. But anyway, he had a very good attitude about his clonus. It can be really stressful for a lot of other people. So I love this box in the book because people get mixed up on spasticity. This is what it is and what it is not. So spasticity is a type of abnormal muscle tone that is velocity dependent. So a lot of times, like I was working with a young girl who had spasticity in her legs, and I had her in the pool walking on the treadmill in the pool. We have underwater treadmills in our pool. And when I had her at a lower speed, her walking was very good, actually. She had a harder time walking on land, but that's one of the things the water does, is it relieves some of the gravity of the situation. So we have underwater cameras, and looking at the camera, her gait looks pretty normal. When we got up to a certain speed, she started having more gait abnormalities because of spasticity. She was getting into that velocity-dependent passive muscle stretch. So, but what spasticity is not, it's not paralysis, it's not abnormal posturing, it is not a particular diagnosis or neural pathology. It's more of a symptom of particular diagnoses or neural pathologies. It's not a hyperactive stretch reflex. It's a component, but it's not that. It's not a muscle spasm, and it's not voluntary movement. So it's not, a lot of times with neurological issues, you might have flexor or extensor synergy, and that's not spasticity either. So it's an often confused term, and we're going to really just briefly hit on it in this class, but we're going to talk way more about it in other classes. So a lot of times muscle tone is confused with voluntary muscle contraction or posture. That's not it. One of the PTs that I work with, who's a neurological specialist, and she's brilliant and amazing, but she said when she was in school, she absolutely could not picture what we meant by tone. What is muscle tone? She didn't get it. And then when she worked with her first patient who had muscle tone, she's like, "Oh, I get it." But it's a difficult concept to grasp. So hopefully you guys will get to work with that patient that clicks it in for you. So there are some disorders that have fluctuating abnormal tone. So they might have abnormal involuntary movements or dyskinesias. So chorea is sort of a involuntary jerky movement. Bellismus is another category of involuntary movement. A tremor is like a twitch almost. And athetosis is a writhing movement. So the consequences of abnormal muscle tone, when you have low muscle tone, it's insufficient activation of the motor units to prepare for a movement or to hold a movement. And it can cause poor posture and difficulty in movements. So it can be damage to the motor neurons, and we'll talk way more about this in neuro. But you can address low muscle tone with electrical stimulation, hydrotherapy, quick ice, which is a cold treatment. You can use that to rehabilitate alpha motor neuron damage. So that's the main focus for this class is what physical agents can we use to address tone abnormalities. So sometimes low muscle tone is caused by insufficient excitation of the alpha motor neuron. So like prolonged immobilization with a cast. And electrical stim is often used after that, hydrotherapy or quick ice again, as an adjunct to therapeutic exercises, orthotics, and functional training. So remember, the physical agent by itself is not therapy, is not physical therapy, but they are adjuncts to active therapy. So high muscle tone, it can be abnormally high excitatory input. So for the CNS injury, stroke, MS, traumatic brain injury, CP, cerebral palsy, can sometimes result in high muscle tone. And associated effects include muscle spasms, joint contractures, abnormal postures leading to skin ulcers, difficulty with dressing, transfers, and hygiene, and stereotypical movement patterns. So high muscle tone can be aggravated by pain, cold, or stress. Spinal cord injuries, a lot of times you have flaccidity initially, followed by spasticity. Same thing with strokes and brain injuries. Management, a lot of times selective range of motion, exercises, prolonged stretch, positioning or orthotics, medications, and surgery. Cerebral lesions like stroke, Parkinson's, multiple sclerosis, prolonged stretch or icing can be helpful in addressing muscle tone. Inhibitory or pressure casting, particularly with people that are have contractures, continuous passive motion biofeedback, and task training. So the task training, a lot of times for stroke recovery and Parkinson's and multiple sclerosis, those are important interventions. So you can see there's some modality interventions, but a lot of them are active interventions that we're doing.